Thank you so much for the invitation. It's good to see a lot of familiar faces. I'm really excited to be part of the Best of ASCO Africa. And in this plenary talk, I'm going to address where we are and where we're going with breast cancer. I'm currently in Seattle at the University of Washington, the Seattle Cancer Care Alliance, and the Fred Hutchinson Cancer Research Center. But as Ken alluded to, as of February 15th, 2021, I will be the Chief Medical Officer for the American Society of Clinical Oncology. And in that role, I'm hoping to have much closer ties with all of my colleagues in Africa and have ASCO be more involved in issues that are relevant to you as well. So, what about breast cancer? What we're increasingly understanding is that cancer is a disease of genes, and understanding the genetic changes that occur as each cancer develops is going to get us the best possible treatment recommendation. We know that most of us, very rarely are we born with cancer. We have normal cells that, as a result of a variety of different kinds of exposures, can have a genetic change that leads to an atypical cell. Then another genetic change happens that can lead to a cancer cell. There may be 3 to 5 and more steps along the pathway over years, but ultimately it's changes in the genes and the resultant changes in the proteins that cause cancer. So a better understanding of the genes and proteins associated with breast cancer are going to lead to better treatment strategies. We are increasingly understanding that breast cancer is not one disease. This slide addresses the genomic classification of cancer. On the left side, we've got various features and factors that can cause genetic changes. Tim Rebick's just talked about some of the hereditary factors. In breast cancer, internal exposures to hormones play a strong role. There can be some external exposures, lifestyle factors. In breast cancer, the infectious agents aren't as common. And then all of those changes lead to different patterns that can happen when we look at breast cancer. So this is a heat map of genomic profiling with hundreds of tumors and hundreds of genes. And when we look at it, this is all breast cancer, we start to see different groups, different groupings based on the gene expression. So where are we going in breast cancer? We are doing better targeting. We're doing individualized approaches. We're looking at better outcomes. We're looking at de-escalating therapy in many settings because we probably hit the max and we're over-treating, at least in the United States, a group of patients. And we have an increased focus on maximizing quality of life for our patients, what is termed the collateral damage of breast cancer and its treatment. Every patient and every cancer is unique. And if there's one message you take home from this talk, it's no more one size fits all. The choice of breast cancer treatment is based on many factors, tumor-related factors, patient-related factors, and then factors related to the therapy itself. With respect to the tumor-related factors, it's important to take into account the stage or extent of disease, the grade or aggressiveness of the cancer. For breast cancer, estrogen receptor and HER2 receptor status are critical. The location of the disease is going to alter your treatment approach. Is it confined to the breast or the lymph nodes? Has it spread to the bone, liver, lungs, brain? And increasingly, genomic profiling is playing a strong role in how we're treating cancer. And I was so thrilled to hear Tim Rebick talk about the African, the Oncogenetics Network with an approach on genetics and genomics being brought to Africa, because this is where we're going. So there are patient factors that we have to take into account as well. The patient's age and menopausal status, her desire for future fertility, the family history of cancer, genetic testing, which you just heard Tim talk about in prostate cancer, the patient's general health and functional status, her previous treatments, if it's now a metastatic disease, And the patient's own goals, concerns, priorities need to be taken into account. And then there are factors related to the therapy, the expected degree of benefit, the expected side effects. The route of administration may be important, whether it's intravenous, oral, subcutaneous, intramuscular. Of course, the key factor in Africa is it available in the patient's country? And the cost obviously plays a key role. So with that, I put up this slide that shows the World Health Organization's model list of essential medicines as it was updated in 2019. And when we ask the question, where are we? I would say that these drugs have been vetted. These are all drugs I pulled out of the list that have relevance to breast cancer. These have been vetted. They've been added to the WHO list of essential medicines. And at a minimum, this is what we should be striving for, to have available for our breast cancer patients. You'll note that under targeted therapy, Trastuzumab was added actually back in 2015 to this list. It was a little bit controversial because of its high cost, but it was added with the caveat that it should only be used if you have reliable HER2 testing and you can afford it. But it was added because it was felt to offer such a substantial benefit to the HER2 population. Now, where are we going, or where are you going? In the United States, I put up this little timeline starting in 1970 up to the present of the US FDA drug approvals for metastatic breast cancer. And you can see we had about 20 years from 1970 to 1990 where we had very few drug approvals. And then we started getting some chemo agents, the aromatase inhibitors, more chemo, and then we entered the targeted therapy realm. And if you look at the bottom, those drugs in yellow, I think that represents about 7 drugs that have been US FDA approved in the United States in the past 18 months. And they are all targeted agents, and they span the ER positive, the HER2 positive, and the triple negative population. Now, this is overwhelming. This is exploding. These are all expensive drugs. They all, for the most part, require some good testing, genomics or otherwise, in order to even know who to give them to. So that's not where I would expect you to be now, but this is what you should be looking at as to where we're going. When I serve as an advisor to the steering committee for the East Africa Adult Hematology Oncology Fellowship Training Program at the Uganda Cancer Institute. And when I come and I lecture to the trainees, I say, do you want me to talk mostly about what you have available or what I have available and where you might be going? And uniformly, I get the answer, no. We need to know what's going on in the world. We need to know, even if we don't have access to drugs right now, where we should be heading so that we're part of the answer to, is this affordable? Is there enough benefit to justify the cost, and that we can be players and that we understand these new agents? So the next part of my talk is really going to get into details on a lot of drugs that you may not currently have access to, but you should be thinking about which ones of these are such home runs that we should be working toward getting these available. Now, along with all of these new drugs that have been approved in the United States, I just show this interesting meta-analysis of what's happened to the average survival of a metastatic breast cancer patient in the United States over time, related to when all these drugs were approved. And it goes back to 1970. We don't really see any change. It's pretty flat out here from 1970 to about 1990. And then all of a sudden the curve starts going up. There was no real change until paclitaxel was approved in 1992. And now all of these other drugs have come along and have improved survival. And of course, this curve I'm showing you only goes out a little bit beyond 2010. So all of those drugs that have been approved in the last 18 months are not even taken into account on this. And most of those drugs have shown improvement in survival. So a key point here in this meta-analysis is that even for estrogen receptor negative metastatic breast cancer, survival has more than doubled between 1990 and 2010 when the patients have access to these drugs. So let's take a little bit of time to talk about some subsets of breast cancer. And endocrine therapy is a key treatment for estrogen receptor positive breast cancer, whether early stage or advanced stage. And we know we have the selective estrogen receptor modulators like tamoxifen and the selective estrogen receptor degraders like fulvestrant that work directly at the level of the estrogen receptor. In postmenopausal women, we have aromatase inhibitors that decrease the last bit of postmenopausal estrogen. And in premenopausal women, we have ovarian suppression that is effective and decreases ovarian production of estrogen. And all of these approaches work either directly or indirectly on decreasing cell growth and division of an estrogen receptor positive breast cancer cell. But where are we going? Well, we know that even with good early stage endocrine therapy, some of our patients relapse. And we know in the metastatic setting that we might get a good long response to endocrine treatment, but eventually virtually all of those tumors are going to become resistant and they're going to start growing again. So we have a set of new targeted therapies where pathways that interact with the estrogen signaling pathway that have been US FDA approved to enhance or overcome resistance to endocrine therapy. And some of those categories of drugs include the cell cycle inhibitors, the CDK4/6 inhibitors such as palbociclib, ribociclib, abemaciclib, the mTOR inhibitor everolimus, and the new PI3 kinase inhibitor alpelisib. All of these drugs have been shown to combine with endocrine therapy and enhance and prolong the response of these drugs and help overcome resistance. We're also learning that endocrine resistance can be tied to acquired mutations in the estrogen receptor gene, the ESR1 gene. And while mutations in the estrogen receptor gene are very rare at the time a patient's diagnosed, so almost never seen in a primary breast cancer tumor, over time with treatment with endocrine agents, one of the mechanisms of resistance that develops is an ESR1 mutation. And so in metastatic ER-positive breast cancer, 20 to 40% of the time, we can see an acquired mutation in ESR1, the estrogen receptor gene. And this is found when we do genomics, and it's associated with resistance to aromatase inhibitors and benefit from those selective estrogen receptor degraders, fulvestrant and some of the newer oral versions of fulvestrant that are under study. Now, in early stage breast cancer, the hot topic is kind of optimizing therapy and de-escalating therapy. We're using genomic assays to determine the benefit of chemotherapy in early stage estrogen receptor positive breast cancer. And we now have picked out a huge group of estrogen receptor positive breast cancer patients who we can safely say have a very good expected outcome and do not benefit from chemo. So the 21 gene recurrence score assay, or Oncotype DX, which someone asked a question about earlier, it can identify patients with early stage hormone receptor positive, HER2 negative breast cancer who can safely forego chemo. And we've seen the results of a trial called the TAILOR-X trial that was a prospective validation study of lymph node negative estrogen receptor positive HER2 negative breast cancer, where patients with a recurrence score in the intermediate range was defined. And then those patients where we weren't really sure if chemotherapy added benefit or not were asked if they would be willing to be randomized to chemotherapy with endocrine therapy or endocrine therapy alone. And what we found in that study in these lymph node negative patients was that if patients were over 50 for a recurrence score of 25 or less, which would be the low to intermediate group, there was no chemo benefit. We could exclude chemo. Those patients did well. And yet age did matter here. And this is where my point about we've got to tailor the treatment to not just the tumor, but the patient For those under 50, that cut point of 25 is probably not right. And we saw that for a recurrence score in the 16 to 25 range, that we were seeing some benefit from chemo. Now, this is hot off the presses. It was just presented yesterday at the San Antonio Breast Cancer Symposium, but this is the RxPonder trial, which was essentially a similar trial to TAILORx, but now we're including patients who have 1 to 3 involved lymph nodes at the time of their diagnosis. And this trial took patients who had a low to intermediate recurrence score. So we used a cut point of 25 for the recurrence score. And we asked that group of patients to agree to be randomized to chemotherapy with endocrine therapy versus endocrine therapy alone. And what we found, and was just presented yesterday, was that if you identified as being postmenopausal at the time that you were diagnosed, then if you had a recurrence score in the low to intermediate range, so 25 or less, no chemo benefit, and you had a great prognosis. So we can now safely feel very comfortable eliminating chemotherapy, even in lymph node positive breast cancer, based on the biology of the cancer and a postmenopausal status. But what we also showed was that in the premenopausal population, we couldn't find a cut point for the recurrence score where we could say there is no group that doesn't benefit from chemo. So in the premenopausal setting, even with a recurrence score in the 0 to 14 range, we saw at least some hint of chemotherapy benefit. And so that's a really important finding as well. I think my personal opinion in looking at all of this data is that I'm not sure it's really the chemo that's needed as much as one of the most common side effects of chemo in young women, which is that we shut down the ovarian function, at least temporarily, and in many cases permanently. So we've got to figure that out too. So let's move on to HER2 positive breast cancer. I'm just overwhelmed by the fact that we now have 7 US FDA approved drugs with HER2 as a target. We've got the 2 HER2 antibodies, Pertuzumab and Trastuzumab. Remember, Trastuzumab is on the WHO essential medicines list. We now have 3 tyrosine kinase inhibitors, small molecules, oral, that go and bind to the internal domain of the HER2 molecule. We have Neratinib, Tucatinib, and Lapatinib. And we now have 2 FDA-approved antibody-drug conjugates. So an antibody that's linked to a chemo agent delivering the chemo inside the cell of a HER2-positive breast cancer and releasing the chemo internally. We have Trastuzumab Deruxtecan and Trastuzumab emtansine, or TDM1. So I'm going to give you just a little data on 2 of the exciting new approved HER2 agents. This is Trastuzumab Deruxtecan. That it's an antibody to HER2, same sequence as Trastuzumab. It has a cleavable linker, and the drug is a topoisomerase 1 chemo agent called DXd. This antibody-drug conjugate was FDA approved in December of 2019 in metastatic HER2-positive breast cancers that had seen prior HER2 therapy. And I just have to show you this slide on why it was approved. This was a study called the DESTINY-Breast01 trial, just a phase 2 trial of patients. 100% had had prior Trastuzumab and TDM1, 2/3 had had prior Pertuzumab. They had had a lot of prior treatment in the metastatic setting for their HER2 positive disease. And this is what we call a waterfall plot over here on the left that shows the best change in tumor size. And if you see this line, if the blue line is going down, that is a response. If the blue line is going up, the best change was progression. There are very few outright progressions. Virtually everybody had at least some response. And this group out here, these are complete responses where the cancer's gone away by our best imaging. This is a powerful drug. We see frequent responses, they're durable. And we're starting to look at whether this drug might have benefit in HER2 lower expressing tumors, such as the 2+ that's FISH negative, or the 1+ due to a bystander effect. And studies are ongoing there. Now, the other really exciting new HER2 agent that was just approved in the US is Tucatinib. And this is an oral small molecule tyrosine kinase inhibitor, but as compared to neratinib, lapatinib, two of the other HER2 TKIs, the Tucatinib is very specific for HER2. And so you don't get some of that diarrhea and skin toxicity that you get from some of the other drugs in this category that also target EGFR or HER1. So Tucatinib was FDA approved in April of 2020 in metastatic HER2 positive breast cancer. So this is an oral agent. And I show you the slides for the primary endpoint, which was progression-free survival, and a secondary endpoint, overall survival. When the curves are spread apart this much, and the blue curve on top is a group that had Tucatinib added to Capecitabine and Trastuzumab, the red curve on the bottom is a group that just got Capecitabine and Trastuzumab. We see a very strong improvement in the progression-free and overall survival for the addition of Tucatinib to Capecitabine and Trastuzumab. And one of the most interesting parts of this study was that they knew that brain mets are a problem in our HER2 positive population. And they also knew that these small molecules, the oral drugs, penetrate, they cross the blood-brain barrier much better than the big HER2 antibodies. So the HER2 CLIMB study actually enrolled a brain metastasis cohort. As you know, brain mets are frequently excluded from a lot of clinical trials, but almost half of the patients on the HER2 CLIMB study, 47%, had brain mets. Now, 60%, the brain mets have been treated and they were stable, but 40% were progressing, either because they were untreated or because they had been treated and they were now having progression. And these are the curves for progression-free survival and overall survival in the brain mets cohort, also very powerful with the addition of Tucatinib showing a strong benefit. And if we looked just at the response in the brain, if we just focused on the imaging in the brain, the Tucatinib cohort had a 47% response rate versus the group that did not get Tucatinib, and they had a 20% response rate. So exciting news for HER2 positive brain metastases patients. And just like I told you about mutations in the estrogen receptor gene, we are now with genomic profiling finding mutations in the HER2 gene. And many of them are activating mutations, meaning that the gene is turned on. So in HER2 positive breast cancer, HER2 activating mutations are rare. At the time of diagnosis, about 1%. After HER2 therapy, if there's relapse, we see them maybe 12% of the time. And when we see an ERBB2 or HER2 gene activating mutation, this is associated with resistance to the HER2 antibodies and a better response from the tyrosine kinase inhibitors. Now, interestingly, because we're doing a lot of genomic profiling, we're also finding ERBB2 or HER2 gene activating mutations in tumors that have been classically designated as being HER2 negative. And this paper shows that HER2 mutations in the absence of classic HER2 overexpression can occur 1 to 2% of the time in an invasive ductal cancer, but up to almost 8% of the time in invasive lobulars. Fascinating. And we also have early data supporting that if we give those HER2 tyrosine kinase inhibitors to this group, now remember, they don't have classic HER2 overexpression or gene amplification, that we can see responses because the HER2 gene's been activated. So this is fascinating, and we would only know about this through our increased emphasis on genomic profiling. Now, what about triple negative breast cancer? I know this is a bigger problem even in sub-Saharan Africa than it is in the US, but even in the US, this is 18 to 20% of breast cancer. It's more common in women of African descent. It's more common in younger women. And even in triple negative breast cancer, we are subsetting it into multiple different subtypes. Chemotherapy has been the main treatment for triple negative breast cancer over the years. This is an aggressive cancer, but we have several new drug categories for the treatment of triple negative breast cancer now, including a new antibody-drug conjugate for triple negative. We've got PARP inhibitors if there is a germline BRCA1 or 2 mutation. We've got immunotherapy now approved in metastatic triple negative breast cancer. And we've got some data on androgen receptor targeted agents because there's a subset of triple negative breast cancer that's called the luminal androgen receptor subset that actually expresses androgen receptor. And we've got data showing it responds to prostate cancer drugs that respond, that have the androgen receptor as a target. So what's the new antibody drug conjugate for triple negative breast cancer? It's called Sacituzumab govitecan. And this is a drug, the Sacituzumab piece of it is an antibody against something called TROP2. TROP2 is a glycoprotein that's overexpressed on more than 90% of triple negative breast cancer. It's also found on other breast cancer subtypes and other epithelial cancers as well. The SN38 is the active chemo that is tagged to this antibody, and SN38 is the active metabolite of irinotecan, and it's more potent than irinotecan. So Sacituzumab govitecan was just approved by the US FDA in metastatic triple negative breast cancer in May of 2020. And this is the data from the randomized ASCENT trial, which was a trial in metastatic triple negative breast cancer that had already seen a couple of chemo agents and it had progression, and patients were randomized to this antibody drug conjugate, Sacituzumab, versus the treatment of physician's choice. And you had your choice of several different chemo agents. And what you can see here, again, I show these curves because there's such an obvious difference between them. The blue on top is the Sacituzumab arm, and the curve on the bottom is the chemo of physician's choice. And we had an improvement in progression-free survival that was statistically significant. The response rate was better with Sacituzumab. And look at that difference in median overall survival in triple negative patients, 21.1 months versus 6.7 months. This drug is really helping triple negative patients live longer. We have ongoing studies in the preoperative and the adjuvant triple negative setting. We've got studies going on in ER positive metastatic setting. We've got studies of this drug in combination with other targets as well. So Tim Rebick talked a little bit about DNA repair and the PARP inhibitors, and this is emerging as something that's important for our breast cancer patients. We know that BRCA1 and 2 are involved in DNA repair, and that PARP is also an enzyme that helps us with DNA repair. So that if we give chemo, we give radiation therapy, if we get DNA damage and we knock out both BRCA1 or 2 and PARP, we get what we call synthetic lethality. It leads to cell death. So olaparib and talazoparib are approved for germline BRCA1 and 2 positive metastatic breast cancer. And where we're going is we're looking at, is there a role for PARP inhibitors beyond germline BRCA1 and 2? So here's another abstract that was presented at ASCO 2020, the TBCRC 048 trial, where we looked at a whole bunch of other DNA repair genes beyond BRCA1 and 2. And this trial enrolled patients who had an inherited germline mutation in any of these other DNA repair genes. And the trial also enrolled patients who had a somatic or an acquired mutation in BRCA1, BRCA2, or any of these other genes. So they weren't born with it, but the tumor, as part of what caused it to become a cancer, acquired a mutation in the BRCA1 or 2 gene. And what we presented at ASCO was that we saw responses when there were somatic BRCA1 and 2 mutations, so not a germline, but an acquired mutation. And we also saw responses for inherited or germline PALB2 mutations. So we're exploring the benefits of PARP inhibitors beyond inherited or germline BRCA1 and 2. And then we have immune checkpoint inhibitors. Immunotherapy's been much more of a success in other cancer types besides breast cancer, but we now have some data and a couple of FDA-approved immune checkpoint inhibitors. drugs that target PD-1 and PD-L1 for metastatic triple-negative breast cancer that expresses PD-L1 on the tumor lymphocytes or on a combination of the tumor-associated lymphocytes in the tumor. So atezolizumab and pembrolizumab are now US FDA approved in that subset. That's about 40% of triple-negative breast cancer has PD-L1 expression, and we've seen some positive data in early stage breast cancer in the neoadjuvant setting. Now, these aren't drugs to be taken lightly, because when you unleash the immune system, it can attack almost all of our organs, not just the cancer. And so if you're going to start using these drugs, you need to be able to carefully monitor all of the organs, the thyroid, the lungs, the colon, skin, liver, adrenal gland, pituitary gland, that can also be impacted by these drugs. So we've got lots of data on the genetics and genomics of breast cancer. And what we know is that we have a progressive genetic evolution of breast cancer, not just what takes us from the normal cell that started it all to the cancer, but also over time in the metastatic setting. We give treatment A, and then as part of the development of resistance, we get a genetic change. And now the tumor's a bit different. And then we give treatment B, and we might get a response, and then the tumor figures out how to get around that treatment due to another genetic change. So resistance to therapies can be the result of changes in gene and protein function. And really, to do the best for our patient, we need to examine tissue over the course of the metastatic treatment. And so I'm making the case that metastatic biopsies are more important than ever, and not just evaluating at the time a patient's diagnosed, but evaluating at time points when the tumor starts growing again or starts doing things that seem unusual based on the prior results. So here's a CT with breast cancer in the liver, doing a tissue biopsy confirming that it's cancer, staining for estrogen receptor and HER2. And if triple negative, I might also ask for stains for androgen receptor and PD-L1. And then I would have access to send for genomic profiling, where I might be looking for actionable mutations, such as an estrogen receptor mutation, a HER2 mutation, a mutation in PIK3CA to see if alpelisib, a PI3 kinase inhibitor, would work. I'm looking now with the new data for somatic mutations in BRCA1 and 2 and maybe other DNA repair genes. I'm looking at tumor mutational burden, microsatellite instability, which might predict for benefit from immune checkpoint inhibitors too. And because it's toxic to the patient, it's complicated, it's expensive to repeatedly do things like biopsy the liver or lung, we're working really hard on, can we do liquid biopsies instead and look at the DNA that's floating around out in the blood? And I know my colleagues at the Uganda Cancer Institute, Nixon Niyazima, who's going to follow with a subsequent presentation, is actively working in this area as well. So I just have to end by reminding us all that all of these treatments are great. They all have side effects. And another part of our goal, where we are and where we're going, is to maximize the quality of life for our patients and to impact that collateral damage of all the treatments that we give, whether it be body image, sexual and reproductive health, lymphedema, bone changes, cognition, menopausal symptoms, or pain. It's our obligation to keep working on that as well. So I'll conclude with this slide. I like to always promote patients as our partners in improving cancer care. At the 2017 World Health Assembly Cancer Resolution, there's a line that says we should continue fostering partnerships between government and civil society, building on the contribution of health-related NGOs and patient organizations. And as part of that, I show you the picture of the Women's Empowerment Cancer Advocacy Network, our first meeting in Africa, which was in Kampala, Uganda at the UCI in 2013. And this picture represents a group of breast and cervical cancer patient advocates from about 10 different sub-Saharan African countries who are working together to empower, to connect, to educate each other and patients with breast and cervical cancer so that they can be part of the improvement of cancer outcomes globally. Thank you so much for your time, and I'm happy to take a couple questions.
Hi, Julie, thank you. Wow, that was a great summary, and it was exactly the title, where we are and where we're going. So thank you. Let's open it up. Any questions? All right, well, I'll start with one. You were talking about a lot of discussion about targeted therapies, CDK4/6 inhibitors, mTOR, kinase. Do you anticipate that those will move into the adjuvant and to the neoadjuvant setting, or are they already?
So none of the cell cycle inhibitors, the CDK4/6 inhibitors, are yet approved and in routine use. But what we've seen over the past few months, including just this week at the San Antonio Breast Cancer Symposium, is we've seen a positive trial, the Monarch E trial for abemaciclib in high risk, mostly node positive, or if node negative, you had to have a high risk population. We saw 2 negative trials, however, for palbociclib in the adjuvant setting. So we really need to sort this out and figure out who benefits from these drugs and who doesn't. You know, it's the whole optimizing of the therapy. You know, can we pick out the women who are going to relapse and then give them more? And can we pick out the women who are going to do fine without these drugs and not give them these drugs? That's the only way we're going to be able to afford it in the US. It's certainly the only way that we're going to be able to afford it in low and middle resource countries. So not yet in the adjuvant setting, and more to come on that.
Yeah, thank you. And just one other question. It was very interesting that you're linking the irinotecan active metabolite to a drug that takes it where it's supposed to go. Makes me wonder a little bit, are any other drugs that when linked may in fact be much more effective than we would have pictured?
Well, I think that's under active exploration because these antibody drug conjugates, you know, the whole process of making them, you could tag them to various different chemo agents. You know, I mean, if you think about the, for example, the HER2 antibody drug conjugate, Trastuzumab Deruxtecan, that chemo agent that it's tagged to, that would be way too toxic to give that drug all by itself. But when you tag it to the antibody and you get it inside the cell, you still get some that leaks out. So there's some toxicity, but it's much, much less than if we just gave that chemo agent, you know, intravenously. So a lot of groups are working on various chemo agents that can be linked and delivered right inside the cancer cell. They're all going to have a little leakage out, but I think the toxicity will be reduced. So an active area of exploration.